us on Dr. ENRICO's memorial lecture, Managing Gallbladder Carcinoma and Surgical Challenges in Rural Healthcare. Dr. Mandal is the professor and head of the Department of Surgical Gastroenterology and Liver Transplant, as well as the medical director of the IGIMS Institute of Medical Sciences. As a and welcome to ICS and Charleston.
At the outset, I would like to thank International College of Surgeons, and especially its President, Dr. Sharif Nazri, and all others who have been, working from last few months to make this program a big success. I am here to talk on a very important topic, that is gallbladder carcinoma, surgical challenges in rural healthcare system. So, you look at India and Bihar. India has the population of 1.43 billion. Bihar has the population of 127 million. The hospitals in India is 54,000. The hospitals in Bihar is 1,900. The population and the hospital doesn't match. And on top of that, the poverty. So, when you take care of patients, you have to keep many things in mind. Not only the disease, the poverty, because there is no insurance for the people, so they have to pay from themselves. They have to raise for blood. So this is my institute, Institute of Medical Sciences in Patna, Bihar, India. And my footfall daily in our hospital is 7,000 per day. Out of that, 2,000 people come to such different various surgical openings. Coming to my topic, gallbladder cancer is among the top 10 most common cancers in India. Incidence is 10 per 100,000 population. India contributes to 10% of total global burden of gallbladder cancer. North India has one of the biggest and highest incidence of gallbladder cancer worldwide. Majority of these cases are present in stage 4, that is 3.3%, followed by stage 3, 22.3%. Detection of gallbladder cancer is early stage is very less than 13.8%. Male to female ratio, it is 1.7 to 2.9. Now the epidemiology and the presentation. Many presents with abdominal pain, that is 80.7%, jaundice with 70.5%, vomiting 3.2%, abdominal masses 8.2%. Around half of these patients, that is 48.5%, present directly metastatic disease. And about one-third, that is 36.8%, present as locally advanced disease at presentation. Now, modes of spread. The major route of spread of GBC is loco-regional rather than distant, either through vascular, lymphatic, neural, transperitoneal, or intraductal. Intraductal has better prognosis, of course. The lymphovascular invasion is associated with dismal prognosis, that is 5 years around is just 4%. This is the pattern of disease in gallbladder cancer. The draining lymph nodes from gallbladder are cystic lymph nodes or periductal lymph nodes. From there it goes to either posterior superior peritoneal, retroportal, celiac, or superior mesenteric, and from there it goes to the intra-aortic node, that is M1, the disease is metastatic. This is a pictorial depiction of lymph node in GBC cancer, where I have shown the lymph node in the celiac artery, and the other is hepatoduodenal ligament. Surgical challenges which we face at our part of the country. Pre-operative workup and challenges. Most patients either are referred late or are in the advanced stage at presentation. Complete history and examination with assessment of supraclavicular nodes and umbilical nodes, FNAC or biopsy is suspicious. Baseline investigations, as you all know, are routinely done, and special investigations in blood are clone markers CEA and CA19.9. Cross-section imaging of CBCT and CMRI are done. PET-CT is not always present everywhere, but yes, in few places it is present. But wherever present, money is again an issue. many people are not affordable to get quick PET CT scan done. If majority hepatectomy is planned, then FLR assessment is done by our radiologists. Patients with jaundice and cholestasis are advised stenting followed by neoadjuvant or palliative chemotherapy. Standard intraoperative steps. Staging laparoscopy is mandatory. In all cases of our GBC or suspected GBC, we do staging laparoscopy to detect small peritoneal, omental or hepatic deposits which are missed on cross-section imaging. Laparotomy, thorough search of metastatic both visually or bimanually palpation is done. Compression followed by simple sampling of intra-aortic cable lymph node for further section is done to rule out mets. Carotid dissection followed by ligation with cystic artery and vein. Cystic artery stump is sent for further section to verify whether it is positive or negative. Assessment regarding arterial section, that is standard 4B5 versus wedge dissection with 2 cm of margin is taken from the liver. Hepatototal ligament dissection followed by extended cholecystectomy. Intraoperative challenges. Staging laparoscopy shows suspicious deposits which is negative on further section. We proceed with extended cholecystectomy with hepatototal ligament no clearance. Liver, omental, peritoneal deposits positive on further section. In these cases, palliative cholecystectomy is considered in cases where patient is symptomatic with good ECG. If tumor is locally advanced with adjacent organ development, then multivisible resection or palliative bypass is done. Thorough identification of hereditary anatomy, avoidance of injury to vital structures during dissection like portal vein, hepatic artery or CVD. If vascular involvement is present, then it signifies inoperability and procedure is either abandoned or only palliative procedure is done. In our surgical tumor board, if resectable, then proper counseling of patients and treatment is done regarding the disease per se, the finances, because they don't have insurance, so they have to be explained how much money is involved. They have to arrange this money, then only it can be done. Blood demand. Blood bank supplies in limited resources. So in every patient of our GBC, we have to tell attendants to arrange the blood. The attendants arrange the blood, then only we can go ahead for surgery. Inoperability, that has to be explained that many times when we have all the clinical findings, that patient is operable, but on table we see that they are inoperable. Complications have to be explained. Prognosis of 5-year survival has to be explained. Neoadjuvant therapy is to be explained. We prefer two-segment value dissection of liver if the liver is involved or only for important growth of GD is there. In cases there is involvement of segment 4 unit by liver, then anatomical radical cholecystectomy involving both these segments is done. If CVD is involved and is positive, the cystic lymph is positive, then CVD exploration is also done. Inflow control with ischemic preconditioning is done prior to hepatic dissection. Anesthesia team is asked to lower the CVD below 5 mm of mercury. Gentle pericarditis method is our approach. We don't use CUSA, we use gentle pericarditis. We use a monopolar or bipolar cautery at the liver margin tissues, but avoid once we are deeper into the liver tissues. Gentle pericarditis helps to do parenchymal fracture without injuring the hepatic veins or portal vein branches. We are very gentle at likely sites of hepatic veins and portal vein radicals while doing pericarditis. Once hepatic veins are identified, then they are ligated both sides with free hands and sutures. Any troublesome bleed is managed with compression. If hepatic veins have retracted or compression doesn't give desired result, then liver sutures made of catgut are used, which are tied above the liver capsule for hemostasis. Post-operative course and challenges. Post-operative patients are kept on non-invasive monitor for UT0. Patients are encouraged for bedside evaluation on day of surgery. Oral are allowed on the day of one of surgery. Rigorous test therapy and excessive spirometry are advised on day 1. Minor bile leaks are dealt conservatively. Major bile leaks, if there is present, then PCD insertion is done under ultrasound guidance so that the bile drains out. Patient is fit to discharge the report on 5th day after our operation. Patient is followed up for 14 days and every 3 months thereafter. Referred to adjuvant therapy based on the histopathological findings. We do active audit of the patients telephonically every few months about general well-being and advanced status. Any unexpected finding of the histopathology is discussed in the tumor board to meet for appropriate therapy for these patients. Now coming to our institutional data from IGIMS Patna. Radiologically diagnosed resectable CAG was 151. Out of this 151, resectable on table were 80. Out of this 80, adenocarcinoma was 60, xantho was 13, chronic cholecystitis was 3, acute cholecystitis was 2, granulomatous cholecystitis was 2. Out of this 151, 49 were locally advanced on table. These patients are 49. We did loop GJ in 9, loop GJ with adenotransfer in 6. Trial resection was done in 11, extended chole with coronal resection was done in 5, RYHA was done in 3, extended chole with glucose was done in 2, extended chole with CVD exclusion was done in 6, and no procedures were done in 7 because they were found inoperable. Out of this 151, 22 were metastatic, where we on table we found omental mets in 4, peritoneal mets in 8, and liver mets in 10. Coming to our data, out of in 2021 to 24, we had did total 1565 cholecystectomies. Out of this 1565, 90 were found to have incidental CAG. Out of this 90, 17 underwent staging laparoscopy and 2 had direct imaging guided biopsy for deposits. Out of this 17, there was no mets who underwent, 15 went under completion cholecystectomy and 2 had still the omental mets on table. Out of these 19 patients, 9 were from our institute and 10 were referred from other institutes to our institute for operation. This photo I have specially kept where the GB mass is showing direct infiltration to the liver. This specimen shows, as with the pointer points, the cellular involvement of the GB. This shows the irregular thickening of the wall of GB, which is the mass. This GB fundal mass, this GB neck mass, this is mass with stones. This we are showing the pectoral ligament teres after the surgery. This slide especially I have kept because it shows that it's totally gallbladder triangle is frozen and we cannot go ahead in these cases. Our problems are that cases come quite late referrals, hardly 4 to 5% are fit for curative surgery. Financial concerns, as I told before, that money is an issue. They have to arrange money, then only we can operate. Blood availability, which I told that attendants have to arrange blood. So if they have money also, if they don't have blood, then we have to sometimes delay our surgeries. Radiological backup is good. That is, and interventional radiologists are always present with us. That is a boom. But sometimes they are not also present. ICU availability is a challenge because a lot of surgery is done. So sometimes we are ready for the surgery, but ICU availability is an issue. So we have to wait still for the our turn to come for ICU. Patient attendants are educationally not up to the mark, so it's very difficult for them to explain about the surgery. A take-home message: any gallbladder wall technique or lymph node in ultrasound, then we have to think for pregnancy. After all investigations, if any suspicious of GBC, staging laparoscopy should be done. Incidentally to GBC, staging laparoscopy should also be done. Every lap colleague, we should examine gallbladder grossly. If suspicious, then send for implant cytology or closed section and proceed accordingly. If you don't have facility for implant cytology or closed section, then don't do further dissection, but send the patient to higher center at earliest preferably before a month for the best result. Before referral, surgeon must write a complete OT note indicating the size, type of the growth of GB along with lymph node status and hepatototal ligament. This is our team. Surgery is defined. Use this approach. Thank you for patient care.
Thank you, Manish, for your talk, and it's very rewarding to see you working on limited resource area for the service.
Thank you.
And just a quick announcement. We we have a dinner tonight sponsored by Baxter at 7:30. So, you guys can meet us in the lobby, 7:30 in the afternoon. It's not a part of the lobby, sponsored by Baxter. And secondly, we'll have a very interesting debate with over in the philosophy of the modern century, two past presidents. And in the meantime, I'd like to introduce Dr. Mahmood Hai, who's giving a talk on ZAHRAWI Memorial Lecture, Foundation of Modern Surgery, Insight from Medical Surgeons. He is the former president and executive director of the Surgical Institute of Michigan, and is the founder and trustee of several organizations, including the Surgical Institute of Michigan, where he served as president and executive director. He also served as an advisory board for major companies like Boston Scientific, Bayer Pharmaceutical, and is involved with the Unity Production Foundation and the Navy School of Philanthropy at Indiana University.
All of you can relax now. You don't have to strain your brain to understand all these scientific things. I'm going to take you through a journey 1,000 years back as to where we started the major foundations of modern surgery. So we're going back to the 7th century, 8th century. Just going to give you a nice glimpse of what happened, where we started and where we are today. I became a fellow back in 1995, and I'm really proud of all the work that the International College of Surgeons has done. Vijay Mitchell and we worked together in the same institution for many, many years. So let's go where we are. So there was a guy called ZAHRAWI back in the 9th century, 10th century. So he, we believe, is the father of modern surgery. And it's my job to confirm that with you today by my presentation. So keep an open mind, and you are the jury to give the final words on that. This is a picture of ZAHRAWI. That was the traditional dress of a surgeon at that time. And the next picture shows ZAHRAWI very passionately, compassionately, with kindness treating a patient in the hospital. So I was approached by Charleston and said, can you give a lecture on back of medieval ages? And I said, it's 900 years. You want me to talk about it in 25 minutes, 30 minutes? So they said, yeah, whatever you can do. So I said, let's be fair to the subject. And with their support and NIC's support, we have now established a ZAHRAWI Memorial Lecture, which will be a perpetual part of the International College meeting. So every year we will have an expert who in this field will tell us exactly what happens, because this is a multi-factional period where all evidence of medicine, surgery, astronomy, astrology all developed, and the foundations of these modern phases were established. So with their strong support, this has been committed, and an initial donation was started. But we need support. We need your financial support. We need your support in every which way. And up front, Maggie has put a little thing which you can use your camera and you can donate, and we want to build this fund so that it's perpetual. So let us take a journey back to the medieval era. And it starts from the 7th century to the 15th century. And it is, while Europe was in still the Dark Ages, this was the Islamic civilization which was a golden age that was in progress. The period was of enormous intellectual activity in all fields: history, literature, philosophy, mathematics, technology, and of course in the medical sciences. It was the world's first truly international inter-religious cooperation where scholarship was shared, coexistence and tolerance was accepted just purely for the betterment of humanity. And you will see that it was not just Muslims, it was Christians and Jews and Hindus, and the literature came from Latin, Greek, Sanskrit. So it formed the basis of this golden age. Unfortunately, the contribution of this golden age to modern civilization has been forgotten, it has been suppressed, and nobody even knows about these 900 years of progress. So I'm going to show you a short clip which will give you what was happening in that era. This is from the Darwin College and University. Okay, how do you move that? Okay, could you raise the volume, please?
They came from all over to read, to write, and to discuss ideas. Lots of languages were spoken: Arabic, Farsi, Aramaic. Women worked alongside men to advance their communities, contributing to education, medicine, and culture. Women were allowed to trade with men. They participated in commerce. Some of them held political power. Sometimes on their own. Wikipedia does not mention that at all. Every illustration is a man with a beard. So then I thought, okay, I'll move on to the general article about the Islamic Golden Age, and I was told improvements to the astrolabe were one of the achievements of this era. Well, I love an astrolabe. I brought my own record. I love it. Have a look at it. It's amazing. Still used today. Absolute beauty. So, considered to be the world's oldest astronomical computer, because it was used to calculate time and location and direction. It was a programmable device used by astronomers in Europe and the Islamic world from the early Middle Ages. Muslim world, you imagine, absolutely vital for determining prayer times, the initial days of Ramadan and Eid. Extremely significant device. What neither the initial article about the Islamic Golden Age, nor the one I clicked through for more detail about the astrolabe, mentions Maryam al-Astrolabe. You don't think her name by any chance is a clue. Her surname indicates her profession. We don't have the exact dates for her, we don't have the exact dates for her, but in the 10th century she was a famous maker of astrolabes. A Muslim woman in Aleppo who took the craft of building these exquisite instruments to the next level. The design of the astrolabe required Maryam to work with complex mathematical calculations and precision. She became famous for her intricate and innovative ideas, eventually leading to her employment in the court of the first imam.
So this was the initiation of the computer age. She established the basis of all modern computers. So that was just to give you a glimpse of what was started in that era. But there were many, many contributors to that. And they were, as I mentioned here, Ibn Battik was a Syriac Christian. He did a majority of the translations from Greek to Arabic, and that made the foundation of the Golden Age. There was the Bokatshu family from, at that time, Iran, who was a Nestorian Christian. And for 5 generations, they produced physicians who contributed to this Golden Age. And going forward, there were Ibn Balkhi, who was the father of modern psychology, Razi, who did the first experimentations in medicine. The ZAHRAWI is the one we're going to focus on, who we believe was the father of modern surgery. He created instruments which are now still being used in a modified fashion. Al-Haytham was the father of ophthalmology. All the optics, the first camera was developed by him. Ibn Sina obviously was the father of that era, and his book, The Canon of Medicine, was used for teaching medicine for 500 years in Europe. Ibn Rushd, who was supposed to be the father of rationalism, a lot of the principles of medicine, the ethics of medicine that was laid down by him. And Moses al-Maimonides, who was a Sephardic Jew, he was a Jewish lawgiver, and some of the laws that he gave are still the basis of Judaism. He was the most intelligent person, and the vizier was made the vizier by the famous Sultan Salahuddin. He said, no, the wisest man in my whole kingdom is a Jew, and he is going to lead the government. So that was the openness of the visions of this whole golden era. This is another very famous person who was totally ignored. She was inherited a lot of property and established a university which is by UNESCO and Guinness World Record the oldest continually operating institution of higher education in the whole world. I'm going to show you a little clip on that. Okay, if you can start that.
Did you know that a woman founded the longest running university in the world? And she did it over 1,000 years ago. In the 9th century, Fatima al-Fihri's father was a wealthy merchant, and when he passed away, Fatima inherited his fortune. But instead of keeping the wealth for herself, she dedicated it to something greater. Fatima purchased land in the heart of Fez, Morocco, and in 859 laid the foundations for what would become Al-Qa'im Mosque and University. She began construction of the mosque on the first day of Ramadan in the year 859. This wasn't just a place of worship, it became a beacon of knowledge, a place where scholars from all over the world gathered to study theology, astronomy, grammar, and mathematics. Over time, Al-Qa'im became known as a center for higher learning, where great minds like Ibn Khaldun studied.
So this is the university as it stands, and I had the pleasure of visiting it, and it's still a very active university where research is done on all aspects, including medicine. So let's focus now on Al-ZAHRAWI. So here is Al-ZAHRAWI seeing a patient. These are all paintings which have been preserved, but we never had an opportunity to see them and appreciate them. So let's go to a little vision of Al-ZAHRAWI. So that just gives you a glimpse of this genius who truly is the father of modern surgery. So he was born in 1936 in Cordova, which was the center of learning at that time, and brilliant academician, a great technician, and he revolutionized from primitive to modern surgery. He formed the basis for surgery. He developed instruments. He also wrote all his works, and they're all preserved. And I'm going to share with you some of the achievements that he did. He lived to the age of 77 and had a very distinguished career and was considered at that time to be an absolute genius. So this is him performing cautery. This was the establishment of the first cautery. It was a chemical cautery at that time. We didn't have batteries and electricity and the cautery, but this was the initial process of cautery where he would cauterize blood vessels. He was the one who developed catgut and started first ligating vessels and taking care of sutures. Because before that, nobody could perform surgery because of the bleeding. Once they cut into tissue, started bleeding, they could not control the bleeding and they could not go the next step forward. So with the help of cautery and ligation, he made surgery doable and possible. So again, I can just touch the surface of his achievements. So I told you about cautery and catgut. He was the first to identify that hemophilia was hereditary. He also pioneered the nature of abdominal pregnancy. Why does abdominal pregnancy happen? He developed the Coker maneuver for dislocated shoulders. For persistent chronic migraine, he was the first one to ligate the temporal artery to get rid of that. And you can see the diversity of his expertise, and that's why I'm calling him a genius. That he made teeth out of bones and implanted them. He was the first to perform tracheostomy, thyroidectomy, developed forceps to deliver breech presentations. He developed treatment for anal fistulas, and then he had a whole series of pharmaceutical experimentation that he did with herbals and identified what side effects they had and which medication is appropriate for what disease and what are the side effects of it. So he laid the foundation of pharmaceuticals, and he was also the court physician of the caliph of that time. Now let us look at some of his specific inventions. So he would literally sit in his workshop and build these instruments, a forceps, how to grasp a stone from the bladder, how to scalpels, how to cut into the perineum to get to the stone in the bladder. And for each procedure, he developed a specific instrument. And replicas of these instruments still present. Dr. Sabag was telling me that he has some replicas of the instruments that he produced. Most of these instruments over the years, over the last 9 centuries, have been modified, improved, but they're still being used. So, again, I've mentioned some of the procedures he did. The use of the lithotomy position for urethral and gynecological procedures. He was the first one to describe it, use it, and was very successful in doing that. He was the first one to use wax to stop bleeding through cranial surgery. So here is a couple of pictures. So if you look at the picture on the right side, this is from his book. So this was a tissue holding forceps. See how precise he made it? So you could pick up the fascia, whatever layer you wanted to pick up. This was a very narrow forceps that he developed that you could introduce aorta to the bladder and crush stones, and then he would irrigate it and wash the stones out. On the other side, you can see the variety of instruments he produced. This is all scalpels, different scalpels for different use, different, like for looking in the ear, he developed that. For retracting the organs, he developed all these. He had syringes that he developed. So this is just a picture of some of the things, retractors, everything was developed by him for the surgical procedures. Even scissors was developed by him specifically for cutting different tissues. And of course, over the years, they have been, sophisticated, and we have now, laparoscopic surgery and robotic surgery, but open surgery was totally established by him. These are some of the principles of surgery that he established, which I think are still true today. He said that physicians must not practice surgery until they're well acquainted with all other branches of medicine. In his medical encyclopedia of 30 volumes, surgery is the last volume, and he gave a very high ranking to the surgeon. He said surgery should not be attempted except by one who has a good knowledge of anatomy, and we know how true that is. Surgical procedures should not be performed by anyone lacking long training and practice in the use of ligation and cautery. And we know now why we have residency programs, fellowship programs, to master the technology, the technique of surgery. But the basic principle of it was laid 1,000 years back by him. He considered surgery as the highest form of medicine, and he insisted on treating all patients, regardless of their financial and social status, with a positive doctor-patient relationship. In his writings, he wrote affectionately of his students, whom he referred to as my children. This is an original copy of his 30-volume book called Kitab al-Tasrif, and I've had the privilege of going to Chester Beatty Library in Ireland and actually see a few pages of that which has been preserved. This book was translated into Latin, Greek, French, Spanish, German, Sanskrit, and this is one of the Latin translations which is also preserved in the museums in Washington. So this 30-volume, first volume just dealt with the general principles of medicine. Second volume was devoted to pathology. Then there was a volume on anatomy, a volume on physiology, pharmacology, therapeutics, how to weigh and measure doses of medication, medical chemistry. There was a whole volume on midwifery, psychotherapy, and the final volume was on surgery, and literally with diagrams he explained how to do each procedure, how to do a tracheostomy, how to do a thyroidectomy, how to do the Coker maneuver, and it was all hand-drawn illustrations that are present in that volume. And of course he described each instrument he developed, the catgut that he developed. Truly it was a cat gut that he developed from the cat's gut. And he described these procedures very extensively, so next generation of surgeons could follow step by step how to do that procedure successfully. And as I mentioned, it was originally written in Arabic, but Latin, French, English, Spanish, Hebrew, and these textbooks are still present in museums that we can identify and see his brilliance in them. So, in the last 15-20 minutes, I have taken you through a journey and tried to summarize 1,000 years of history by giving you a glimpse of the golden age of Islamic civilization. I shared with you the brilliance of Maryam al-Astarabi and Fatima al-Farihi, but we looked at al-Zahrawi, and I hopefully convinced you that indeed Zahrawi is the father of modern surgery, who laid the foundations of surgery that we practice today. And hoping it has stimulated your appetite to look further into this phenomenal period of human civilization. So there is a little handout, you can take it, and you can look up any of his works, you can look up other contributors in that era, but it's a phenomenal study. And now you can go to Wikipedia, you can go to other sources and look at what did Ibn Sina do, who did the basis of optics, Ibn Haytham, what did he do, what experimentation did he do. It's a journey that you can, I hope you will enjoy. And I'm really thankful to Shahid personally and to ICS, US section, to introduce this whole era of the medieval golden age of our civilization. So with that, I'm going to end, but please explore. And I hope I have convinced you that al-Zahrawi indeed was the father of modern surgery. Thank you very much.
So we are excited now to have a great debate between robotics and laparoscopy.